Good afternoon, and welcome to today's presentation, Medication Management, Playing Our Part to Reduce Opioid Use. My name is Valencia Harper, and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout this presentation. Please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will include polling questions. We encourage everyone to participate as we value your interaction. Today's presentation will also be recorded and later uploaded to our Health Visions Delmarva PTN YouTube channel. You may find the link on the flyer included in the invite to today's webinar. Today we are privileged to have three speakers, and at this time I would like to introduce each of them individually. Our first presenter is Dr. Sarah Chenard. Sarah Chenard, MD, is the Medical Director of Community Care of West Virginia. She has an undergraduate degree in neurobiology from the University of Vermont and conducted scientific research at the University of California, San Diego, after graduating magna cum laude from the University of Vermont. Research in biomedical health sciences piqued Dr. Chenard's interest in medicine. She is an Alpha Omega Alpha graduate of Marshall University School of Medicine in West Virginia and served as chief resident in the Department of Family and Community Health. Dr. Chenard served as lead physician for the Meaningful Use Vanguard Group for the state's Regional Extension Center for Electronic Health Record Adoption. She also has had the opportunity to participate in an expert panel with Health Resources and Services Administration for Health System Realignment. She is an executive member of the West Virginia Health Information Network Board of Directors, West Virginia State HIE Agency. Since 2003, in addition to serving as the Medical Director of Community Care of West Virginia, a federally qualified health center, she has served as the Chief Clinical Advisor for the Community Health Network of West Virginia and as a member of the West Virginia State Innovation Model Grant. In recognition of her efforts, Dr. Chenard now serves as National Faculty for the Center for Medicaid and Medicare Services Transforming Clinical Practice Initiative, where she is a regional cluster coach working on health system transformation and pay for performance initiatives. Dr. Chenard serves as Medical Director for the State Insurer Public Employees Insurance Agency. She was recognized by the West Virginia Rural Health Association as Rural Practitioner of the Year in 2008 and was featured in stories by Governing Magazine and CNN on health reform. She is a co-founder of the Fayetteville Skate Park, a multifaceted recreational facility promoting physical activity and wellness. For her efforts in promoting free, healthy activities for her community, Dr. Chenard was recognized as her hometown's Citizen of the Year. Our next presenter is Dr. Edward Sobel. Edward Sobel, DO, is a retired senior partner, managing director, and was a family physician at Family Practice Associates of Wilmington, Delaware. He is currently the medical director of the Health Visions Delmarva PTN, the Healthcare Quality Improvement Program for Quality Insights of Delaware, and the Delaware Regional Extension Center. Dr. Sobel is a senior attending staff member and executive committee member of the Department of Family and Community Medicine, Christiana Care Health System, Wilmington, Delaware. He is board certified in family practice. He currently serves as a preceptor for the Department of Community and Family Medicine's residency program at Christiana. Our next presenter is Cindy Eisman. Cindy Eisman, MBA, is the project manager for Health Visions Delmarva, a practice transformation network working through the CMS Transforming Clinical Practice Initiative. Cindy has over 30 years of experience in healthcare, starting in the area of health information management and expanding her skills in areas of expertise to perform improvement, operations, management, healthcare, financing, and practice transformation. Cindy has been a CEO, COO, and Regional Quality and Operations Director with Health South, Kindred, and several community hospitals. Cindy is a native of Pittsburgh and graduate of the University of Pittsburgh and the Troy University in Alabama. I would now like to hand it over to Cindy to begin our webinar.
Thank you so much, Valencia, and thank you to Dr. Sobel and Dr. Chouinard for being our speakers today on this presentation. We really think that this is an important topic for us to be talking about with our network, and we hope that you find this to be a very practical and useful presentation on the topic of doing our part to help stem the opioid crisis. So our learning objective today is to really energize our network of clinicians to take a more aggressive leadership role in addressing the current opioid crisis in our medical neighborhood. Some of the questions to run on, things that we'd like you to be thinking about during our presentation today, are how can I best manage acute pain in my patient population following the American Pain Society recommendations? How can I best manage chronic pain in my patient population following CDC recommendations? When opioids are an option, how can I effectively manage their use? And when addiction is a risk, what alternative modalities are available and addiction treatment resources available in my community? Just to kind of frame the issue that we're dealing with here, drug overdose is the leading cause of accidental death in the U.S. From a 2015 study of the subject. There were 20,101 overdose deaths related to prescription pain relievers and 12,999 overdose deaths related to heroin in 2015. In Maryland and Delaware, the problem is just as large as it is anywhere in the state. In fact, there are two of the states ranked in the bottom, if you will, in this category in that 2015 study. The other thing that's important to point out is that certain things in this crisis have increased in parallel over time. From 1999 to 2008, overdose death rates, the sale and substance abuse disorder treatment admissions related to prescription pain relievers all increased in parallel. And during that same time is when we really saw an increase in those overdose deaths. So given these statistics, it is really important that we be aware of the problem and what possibly we can do to help to try to mitigate the issue. So it's time now for our first polling question. So if you would launch that, Valencia.
And our first polling question reads, the management of opioids is a problem in my practice that we need to start to address, a problem in my practice that we are already working to address, or no longer a problem in my practice after we implemented strategies to address, and not a problem in my practice. So we have about 15% that have voted. Almost half have voted so far. So it looks like we have about 17% say that it is a problem in my practice that we need to start to address. 17% a problem in my practice that we are already working to address. 33% no longer a problem in my practice after we implemented strategies to address. And 33% not a problem in my practice.
Well, those are interesting results. I'm really excited that 33% of those on the line have already taken steps to address the problem and really feel that it's making a difference. Hopefully after we talk today, we'll be able to see that number on the bottom change a little bit, because I do want to make sure that we are getting the message out to our community that it's really something that impacts all of us in one way or another. And so hopefully with some of the information we provide today, we can shed some light on that. What I'm going to do next is hand over to Dr. Chouinard, who's going to give us a little bit of a story, the story of Community Care of West Virginia, and how they have identified the challenge and helped to address this problem in their practice. So Dr. Chouinard.
Yeah, thank you so much. So I want to just begin by framing who we are and how we began on this process. So the first slide that you'll see from my section here talks about leadership involvement, both state and national. And I mention this just because I'm not really speaking only from the perspective of a physician who's working in a health center who's addressing this, but I've participated on a team with NAC who is trying to figure out what strategies are most important in addressing the opioid crisis. And I also serve as the state's medical director for our public employees health insurance agency. And in that role, we've collaborated with the university in West Virginia to create something that's called the Safe and Effective Management of Pain program. And I'd be happy to get into details if people would like to hear more, but there's a web link embedded in the slide that allows you to read more about it. But in essence, the insurance companies have some skin in the game now, in that they are putting caps on the amount of pills that they will cover in a given month based on morphine milligram equivalent. And I'll explain that in just a moment. So if you go to the next slide about pain management integration into a patient-centered medical home, we realized that there was an article on the front of the New York Times that said that ground zero for the opioid crisis was rural West Virginia. And I understand a lot of other people have claimed to be ground zero as well, but they made it official, and we said to ourselves, well, we're going to have to address this overtly. And so we thought, in combating this, why are we doing this? What really is our goal in looking at this? And so, first and foremost, can we reduce into the fact that it's over-prescribing, not prescribing? Because what we found in our practice is we had physicians who were over-prescribing, and we had physicians who were so afraid of the ramifications of writing opioids that they had patients in pain who were receiving no medication at all. So second, we wanted to reduce the number of pills in a rural community. I have many a sad story about patients who would come into me and say, I don't really want to be given an opioid because if the word gets out in our community that I have opioids, someone will break into my home. People will find out at church, and then I'm going to be a target for theft or otherwise victimization somehow. And so we really wanted to make our communities safer by trying to remove this opioid overprescribing out of the equation. Next, our doctors were frustrated. I'm sure many of you have been there as well, that, they feel like patients would come in and there was a lot of pressure from the patients to write for these medications, and often they wanted to end the conversation about pain as quickly as possible so that they could get to what they considered their real bread and butter as family doctors, treating their other chronic illnesses. And so the docs wanted a solution as well. The next few things really came around, okay, so when patients come in pain, everybody was doing something different. We would have some people who would be handling it one way, another group of people handling it another. And so we wanted to standardize across all of our practices. We have 15 outpatient offices across 9 counties. And we wanted to say, what is important in the workup of pain? And I don't have this explicitly stated in a slide, so I want to take just a minute here. The pain scale that the DoD uses, the DVPRS, is a pain scale that incorporates not only the 0 to 10 pain scale, but it has what they call supplemental questions that get into how is this pain affecting your sleep, your mood, your functional activity, and it really it collects a bigger picture and shifts the conversation from being about let's get your pain to zero, but instead let's make your pain such that you can improve these other areas of your life. So that was an innovation that really created an impact. And then standardizing our compliance monitoring, and I'll talk about that on the next slide. And then finally, like I mentioned, offering help to people in pain. So we don't just say, hey, we don't write pain pills. We don't want to be accused of being a pain pill. We're afraid of legal ramifications, so we're out. We did not take that approach. And so if you'll go on to the next slide, West Virginia, and I know every state is unique, West Virginia has something that's called OFLAC, and OFLAC is the Office of Health Facility Licensure and Certification. And they define a pain clinic as anybody who is writing greater than 51% prescriptions that are pain prescriptions in any of their offices. And so what we did is across our 15 offices, we asked all of our chronic providers to not write chronic pain medications for patients until they had first been seen by our internal pain specialist. And so because he is a pain specialist, he does have greater than 51% of his patients on these medications. And so it put us as being a center that would require going through this certification process. Well, it ended up being a really good thing because it made us look at some things that we weren't doing routinely. One is looking at the prescription drug monitoring program every time a patient comes into the office, a urine drug screen every time that they come into the office for their pain visits, and then creating shared care plans with the pain specialist that is employed by our FQHC and our primary care doctors. So next slide, please. The other part of this that's been really important to us is we wanted to get our family doctors back to being able to concentrate on basic family practice conditions and problems. And so if you look at this table, it has blood pressure control in diabetic patients, hemoglobin A1C that's less than 9, and the number of opioid scripts that were written by primary care providers over the course of a month. And so that's opioids for chronic and for acute pain. And so if you look, in 2013, before we implemented this program, I won't read it to you, but you can see the data there. And if you compare it to 2017, what happened in this time period is we took a really consistent and predictable stance on how we treat pain. And so you can see that while, of course, there are other factors that would come into play with treating diabetic patients, what we believe is that one of the things that really contributed to those numbers moving in the right direction is that the patients who were diabetics, who came in so poised for discussion about pain, understood then that we are coming back to the primary care providers, that the conversation was really going to be about their diabetes, their hypertension, their cancer prevention screenings, their psoriasis, whatever. And so we shifted the conversation away from pain. So we think that helped. And then if you look at the total number of scripts that were being written in 2013 compared to 2017, that's a really significant difference. And we really attribute that as well to this sort of centralizing of the management of chronic pain within our offices. So let me stop there, and I will turn it back over to you, Valencia.
Okay, we're up for our next polling question. It asks, I know and routinely use evidence-based pain management guidelines 100% of the time, 75 to 99% of the time, 50 to 74% of the time, 25 to 49% of the time, or less than 25% of the time. We have about 29% that's voted. Almost half the polls are in. Just a few more seconds. We have about 17% say 100% of the time, and 83% 75 to 99% of the time.
Okay, thank you, Valencia. That's pretty good. A pretty good result. Of course, we want to shoot for 100%, but that's a really good place to be starting here. I want to hand over now to Dr. Sobel, who's going to talk to us a little bit about best practice for both acute pain and chronic pain management. Dr. Sobel?
Thank you, and good evening, everybody. In thinking about this, and as we prepared this, came back to the fact that I think as clinicians, we got lulled into a prescribing habit of opioids, cover the pain, make the pain go away, and we kind of ignored the complications going on. And you have to really sit and think about it, that there's no way that we're going to make the pain go away 100%. We'd like to do that for our patients, but it's really not realistic. And so I think we have to, first of all, have our patients acknowledge the fact that we can't control 100% of pain. So looking at best practices for acute pain, we're going to divide this acute and chronic. There's a number of typical illnesses that require severe pain reduction. There are things that obviously cause a lot of pain and would be appropriate, perhaps, for opioid treatment. We need to make sure that we obviously treat the underlying condition, that we intervene and make adjustments and multimodal approaches. It used to frustrate me that patients would come from the emergency room with illnesses or injuries with big bottles of opioids, and they didn't need it. I mean, they were going to be better. I'll use my wife as an example. She was involved in an accident where she totaled her car, got taken to the emergency room in an ambulance, and after the usual routine, came home with crutches and a big bottle of opioids, and was told it was going to take a couple weeks for her to start to feel better. By the next morning, she felt good enough that she was basically back on Tylenol. She ditched the crutches that they gave her, and yet we now have this bottle of opioids that was sitting there. And a lot of times, I think the emergency room, there's a lot of opioids given when really the patient could be referred for follow-up care on a shorter basis. So we want to make sure that we treat appropriate and use multimodal approaches. And I think the other important thing is preemptive analgesia. We know the patients are going to be in pain. It's clearly better that if we can reduce their pain before it peaks, they need less pain medication. It's the fear of the pain that I think often drives the patients to use of opioids. In the corner of the slide on the lower right, there's a reference from the American Pain Society, and it's really a good one. You can click on it and get the PDF, and they give you an excellent outline for managing acute pain and also chronic non-cancer pain. So that would be a good one to check out after this presentation. So let's go on to the next slide. So what can we be doing for pain management? And this one came from the AAFP, and again, this will be another resource that we're going to have for you at the end of the presentation. Long list of resources that I think will be valuable for you. We can start out with acetaminophen maximum dose, or we can use an NSAID. And actually, an NSAIDs, like I talked about, we want to really cover the pain. I personally don't like ibuprofen. I think that it's too short acting. The patients, as it wears off in 4 or 5 hours, become painful again, and then they're popping another pill, and so there's this constant fear. So, for instance, when I use an NSAID, I often will use naproxen because it lasts 12 hours. So if they take it breakfast and supper, we get a lot better pain control. There's other medications as you go down the list there that are both long-acting, and opioids, if needed, can be used in combination with, for instance, acetaminophen or NSAIDs, and that really works in making a difference. So these are studies that have clearly marked how we should be using pain medication. And again, this resource from the AFP will be available at the end of the presentation. Next slide, please. So we've talked about acute pain. The one that probably gets most of us is chronic pain management, or maybe chronic use of opioid medications. So we really want to emphasize the non-opioid therapies as much as possible. And a lot of these patients are depressed, they have problems going on. If you're in pain and it's frustrating and you can't work, or it interferes with your activities of daily living, understandably, patients get depressed, they become anxious. How are they going to support their family? How are they going to take care of the kids? But whatever it might be. And so we really need to be aware that there's often mental health conditions which need to be treated, not with pain medication, but with other appropriate medication. We want to make sure that patients are engaged in this discussion, that they're not passive in this, and that they can participate. It's interesting, I'm here in Delaware, and I remember years ago, patients who worked for a DuPont company, if they were injured on the job, DuPont was really intent on getting them back to work. And I once talked to the plant physician, and I said, the patient's no way going to be able to go back on the line doing what he was doing for the company until his condition improved some. And he said, we're going to put him to work in an office job until he's ready to go back on the job. I said, well, what can he do? He said, we'll find something for him to do. Even if he counts paper clips and divides them up into little compartments for us, we will find something, because a patient who goes back to work begins to feel worthwhile in doing something, and that they're not hopeless. We need to use disease-specific treatments where we can. So if we're talking about neuropathic pain, merely covering the pain with an analgesic may not be the way to go. We may need to use something like gabapentin to treat the neuropathic pain. We want to use first-line medications, preferentially, as we saw on the previous slide. We want to consider intervention. So patients who have chronic joint pain may benefit, for instance, from a corticosteroid injection rather than continuing with non-invasive therapies. And then lastly, multimodal approaches, including rehabilitation. Patients will often be resistant, but when offered the opportunity and kind of encouraged to do that, it's amazing. Recently I had a patient when I was teaching the residents, working with the residents, and he said, well, I did rehab once. So the question became, well, how did it work for you? He said, it was great. He said, all my pain went away. I said, let's do it again. And that's what we did. And he had not really thought about the fact that rehabilitation had helped his chronic pain once, and we took him back again. And again, we have another treatment for chronic pain, reference at the bottom, and we'll have this available to you from the CDC. So that's out there. Next slide. So the three takeaways, I think, from my point of view, is start safety, start slow, start with a medication. I mean, hit the patient with a medication at a maximum dose that's going to relieve their pain, but not necessarily with an opioid. Engage the patient, get them to participate in it. It's amazing the insights the patients will have and the insights you can draw from them about how they're going to treat their condition. And lastly and importantly, behavioral health is really important. Patients who are chronic, who have pain for a while, really tend to be depressed or anxious about it, and we really need to face that and not just say, well, take more pain medications and you'll be happy tomorrow. So those would be my big three on this. So having said all that, I'm going to turn it back to Dr. Chenard to complete this presentation.
Thank you so much, Dr. Sobel. So let's talk a little bit more about guidelines. When we took the poll, some of you said that you're using guidelines all the time, but some of you are not. And I think that at least for the primary care side, and I think that the only reason that they emphasized that this was primary care is because these guidelines might not be suitable for someone, for instance, who is a pain specialist. But for those of us who are not primarily treating pain, that was really the target audience for these guidelines. They came out in 2016, and if you go down into the handouts, we have most of these in the handout section, so you're welcome to access those. In addition, we have the link here in front of you, but we've just highlighted what the main points are from these guidelines. And in a future slide, I'll get to this concept of morphine milligram equivalent that I alluded to when we were talking about the SEMP program that we developed with our state payer. But let's walk through some of these. First and foremost, opioids are not first-line or routine therapy for chronic pain. So I gave a presentation in Washington, D.C. about a year ago, and the number of people who came up to me afterwards and said, boy, I really heard and agree with what you said there, when I said, opioids have become in a lot of communities like aspirin used to be. And what I mean by that is people go up to each other and say, oh man, I have a headache, do you have an oxy? And the answer is often, yeah, yes, I have one of those in my purse, in my pocket, in my car. We have a lot of coal mines in the area where I work in West Virginia, and one of my minor patients said to me that, oh, anytime you have an ache and pain and you're at the mine, you can just ask anybody and they can give you an oxy. And so, you know, it used to be that I would see my grandmother carrying aspirin around in her purse, and then, you know, my mother maybe has naproxen in her purse, and now what's happening is these mothers are wandering around, and oxycodone has become what people think is just simply the place we start, and it certainly isn't. Second, establish and measure goals for pain and function. So I mentioned this as well. Just as an example, we have a lot of the intake on our patients is kind of a heavy lift, but we do that because we think it's important. And one of the things that we assess every time is an assessment for sleep apnea. So we ask a standardized tool for sleep to ask patients, you know, do you have sleep apnea by symptoms? Are you a snorer? What's your quality of sleep? Because those patients are going to be at higher risk for respiratory depression for some of these medications. So asking that is really going to be important when beginning the workup for any patients who might be wandering down the path of chronic use. Discuss the benefits and risk and availability of non-opioid therapies with the patients. So what do we mean by non-opioid therapies? Well, the research now is good for things like yoga, things like chiropractic care, things like biofeedback. And these, you know, while I feel like it was not very long ago, I suggested those in a lecture, and I was laughed at the lecture that, like, oh, come on. And not only is the research pretty good now, but on top of that, you know, we just make assumptions that patients don't want to do the hard work. And for the most part, you know, we as people, including myself in that role, you know, it's harder to do lifestyle modifications. It's harder to be engaged in diet and exercise, et cetera. But I put onus back on myself and the physician community that we don't often say, let's really talk about all of the options that exist before we go straight to medications. Forget opioids, just all medications. I think also Dr. Sobel already touched on this, use immediate release opioids when starting. That's really important. And then this is a slogan. I don't know if it was, you know, if it's truly credited to the CDC, but they use it, this idea that we start low and go slow. And then again, Dr. Sobel mentioned this about the example with his wife having, you know, a bottle of oxycodone laying around, that when we do need to give opioids, prescribe no more than needed. I don't know if it's just our state or if it's nationwide, that CVS has come out and said we're going to put a cap on the amount of pills that we'll fill regardless of the prescription. So speaking to this, okay, you can get your prescription partially filled only because that's likely to be sufficient. Do not prescribe long-acting or extended release opioids for acute pain. And then finally, doing reevaluation repeatedly, reducing the doses, tapering the doses, all of these being highlighted in the guidelines. Next slide, please. Okay, so morphine milligram equivalent. So if you look here, it's really a simple math equation, but just walking through it without going into any examples or any real detail. First and foremost, what's the total daily amount of each opioid that the patient takes? And each is an important part of this. And I'm going to talk in a minute about the prescription drug monitoring program. I think one part of this is, sure, there's the opioid that you prescribe, but are there others that they're receiving elsewhere? That would need to be calculated and included in this equation. And then second, convert each to a morphine milligram equivalent. So you multiply the dose for each opioid by the conversion factor that you can see in this table. So as you can tell, there are those that are like hydrocodone, which is a 1, meaning it has a morphine milligram equivalent that's equal to morphine, and then it goes down for things like codeine and way up for things like fentanyl and high-dose methadone, etc. And then finally, you add those together and you come up with a number. And so the two important numbers that I would want you to remember from this presentation, the numbers are 50 and 90. So for 50, the CDC guidelines recommend that greater than 15 morphine milligram equivalents daily is a flag that this patient needs more frequent follow-up. So it's not that that's too much, but this is a person who you're not going to want to say, okay, we'll see you on occasion, but rather, how frequently can we get you in the office so that we can begin really incorporating alternative therapies in an attempt to reduce the dose and ideally, get the patient off the drug. And then the other is 90. And according to this new guideline or relatively new guideline from CDC, 90 is something that we just want to avoid completely unless it's justified. Well, what does justified mean? Justified means it's cancer pain. Justified means the patient has a long history of trying and failing and a real failure, not just, yeah, I went to a yoga class and that didn't work. Or, yep, I went to a chiropractor once, but I didn't think that was for me. And not, I tried, a non-steroidal for, 3 days and gave up on it. But a real exhaustive trial of all other things with a substantiated diagnosis. Okay, next slide, please. Okay, so let's talk about the prescription drug monitoring program. This program is state by state, has different expectations and ways that you can log in and whether or not it's integrated into your electronic health record, et cetera. But I think this is perhaps one of the most valuable tools that we have in trying to understand really how much drug a patient is getting, receiving, taking, whether they're using the drug themselves by toggling that to the urine drug screen, et cetera. So for us, the way that we've really been able to get a handle on which of our patients are compliant has been through incorporating the PDMP into our workflow. And what I mean by that is as the patient's being worked up to see our pain specialist, the PDMP is already printed. It's already been placed in the patient's chart. And typically our nurse will call attention to it and say, I'm going to be asking Dr. Hockenberry to discuss this with you. I just want to let you know that it shows that he's the only person you've been receiving these medications from. Or I see here that you've also received this from the emergency room and from Dr. Such and Such, and I'll be sure to call his attention to that. So we're planting the seed in the patient's head that this is not a conversation that we're going to save until the end of the visit, but that we want to understand first and foremost, if your contract stated that you would have one prescriber and one pharmacy, how do we know that that's happening? And instead of having a conversation about it, it's almost like the proof is in the pudding here with the PDMP. And then there's some information here about the PDMP in Maryland. CRISP is who supports and integrates that. You do have to register for it, but the access is available, and you can see the link there on how you can get signed up to be able to have access to the PDMP. Okay, next slide, please. Okay, so Cindy, I'm going to turn it back over to you so that we can go through some questions and have a discussion with both me and with Dr. Sobel.
Okay, great, Dr. Chouinard. So, with our work that we're doing out in the field with all of your practices, we've talked about this topic with some, Maybe not with all, but at different times the issue has come up and we've had some conversations. So what we did was, as a group, pull together some questions that we've received in the past, or issues that we've identified, and we wanted to have an opportunity to have a bit of a conversation about them. So the first question that we have is, what other alternatives are out there that really work for chronic pain? I've tried physical therapy, but it doesn't seem to help my patients.
Cindy?
Yeah. Did you hear it?
Yeah, I'm sorry, you cut out. Could you go ahead and repeat the question, please?
I am so sorry. What other alternative modalities are out there for chronic pain? I've tried physical therapy in the past, but it doesn't seem to help.
Sure thing. So I mentioned this a little bit while we were talking. My best experience with this is through our university, West Virginia University. We're just in the infancy of this program, but what the university has put together is a multifaceted, multimodal center for treating pain. And in so doing, their hope is that as a patient walks through the door, that they do enough initial screening that they make a decision about where this person is going to be best served first and foremost. So instead of the patient making an appointment with a physician, like the patient goes and seeks out an acupuncturist or seeks out an anesthetist, a chronic pain specialist, a family doc, etc., they show up at the center. And based on the results of comprehensive screening questions, the patient might first start out with behavioral health. As I would assume all of you on the phone have had personal experience with, so much pain is connected to psychiatric pain, and there's so much pain that shows up in the body that is, okay, maybe an x-ray shows that they have mild spondylolisthesis, but really their pain is from some emotional baggage that they haven't yet had the opportunity to work through, or that they had a traumatic incident. The injury itself has healed, but the trauma around the injury hasn't healed, and that's really showing up as physical pain. So sometimes what will happen is, instead of jumping straight to the physician, they will go to licensed counselors. They will, if it's a person who really has a significant musculoskeletal injury, it's well documented. All of the screening questionnaires suggest that their pain is specifically related to, for instance, their ability to perform their job as a manual laborer. That person might start with the chiropractor. And so sometimes a patient will work through all of the arms of this center, and they'll end up touching every person there. And sometimes they'll go straight to the doctor, and it's simply about what medicine's the best medicine, having failed other things. So when you say, hey, I've tried physical therapy and that doesn't work, I think part of it is there are physical therapists who are really looking at treating chronic pain, but some of them will say that, you know, they deal with acute pain, you know, post-surgical pain, those kinds of things. And it's about going out and really surveying the community and understanding what other things are there. And Cindy, if you don't mind, if it'd be okay, I would like to kind of just elaborate on that a little bit, because I think a lot of things that people then say is, well, that's not covered by their payer. That's not covered by health insurance. And so I've gained such a unique perspective working just a day a week for a payer. And so while it's no work that I would have ever really chosen to do, they were in a jam, they lost their medical director, they asked if I would just come and be willing to work through some of their appeals and help them temporarily. So I filled that position thinking I would be there for a few weeks, and it's been now 2 years later. And the reason I stay is, boy, it has been like a fellowship for me. I mean, the education I have had by understanding the payer side has been really eye-opening. And so I better understand how resources are allocated within an insurance company. And I think that when, you know, you look at a plan that either is 80-20 or that you have a premium or a deductible that you need to meet, that we need to have a conversation with patients that say, look, not all of this is going to be covered, but this is the right care. And so while we notice that there is a shift and that now, for instance, there is cover for acupuncture by some of the payers, and there is coverage for massage therapy by some of the payers, that we still need to say that it can't be that just being covered or not by the insurance is the barrier. And so I understand. I work in arguably one of the poorest places in America. Rural Appalachia, West Virginia can get pretty destitute, and patients don't have the ability to pay out of pocket for things like going to an acupuncturist. However, that being said, a lot of them, if we can create value for it, will say, okay, it's worth it at least for me to go once and understand what are the things that I can be doing to self-manage at home. So I think that, I can imagine some of you would be eye-rolling and thinking that that's kind of Pollyanna to think that patients will go there. But I challenge and push back on that and say we have to suggest to them that there is data that says that that works. And if getting off of pain medications is one of their goals, it's a long, slow process, but you can get there.
That's great feedback. And, I think that I heard two things pretty clear. One is, even if we don't have in our communities the kind of a center that you guys have been able to develop there with a multimodal therapy center, doing a full assessment of the patient and really understanding what all the underlying things are that might be driving their pain is just so very important, and using what resources we do have available to their fullest extent. And then just that idea of, it's not all about, well, what does the insurance cover? Some of it is, it's just a lifestyle change, not just, but it's a lifestyle change. And that is harder for all of us to do, but it's something that we have to always be working to encourage our patients to take more responsibility for and be more engaged in. Okay, I have another question. I get patients new to me as a PCP that have been on opioids for years. How can I get them to change?
Dr. Sobel, did you want to answer that, or would you like me to respond to that?
Well, I can, at least start on it. I think that we have to, tell the patient what you're doing isn't working, because that's why you're here. And I think that we can look at some things to be done to maybe change the way things are. And I was thinking, and your previous answer, one of the places that I found great success was vocational rehabilitation. We have patients who have an injury which precludes their going back to their previous occupation, but they're bright people. And it's just that, with the pain or disability that they have, they're not going back. And I've sent patients to vocational rehabilitation to get training, which the state pays for. So, there may not be an income while it's going on, but at least the patients can look and say, well, there's an opportunity for a job that I can do within the limits of my discomfort or, physical restriction. So, that was actually, another thought. But I think if patients are presented with a positive outlook, to get back to the question, that we're going to try to do something, and we've been successful previously, I think patients will go along. I think they would like a lot of times to be off of their medication. They may not admit that, but I think a lot of times they would be grateful that they could be off the medication.
Yeah, and I think what I would add to that, I think you're exactly right, and what I would add is that my experience has been that patients who have been on their meds for so long don't remember life without them. And so the other part of the conversation is addressing addiction, that to say, whether it's, it was accidental or, it doesn't matter how we got here, but now being on these medications, depending on the drug, you can and will withdraw from these, and we can get you off of this, but setting expectations that this isn't going to be easy. And so I had a patient once come into me, and he was this really old man. He was like 90 years old, and he had shoulder pain, but had no injury, and he had full range of motion. There was no reason for him to be on hydrocodone 3 times a day, and he had just been on it forever. And I said, we really need to get you off of this. And so we went through this long tapering process and figured out how to do it. And he came back to me and said, and he wasn't being funny. It was actually kind of a heart-wrenching thing for me personally, but he said, I've spent weeks cursing you and, shaking my fists, wondering why you're doing this to me. And now that I'm off and I'm through it, I feel better now than I have felt for the last 10 years that I've been on this medicine. I'm so grateful. Thank you, thank you, thank you, thank you. And so it was that push, it was having that push to go do it that he just, he didn't even know he wanted. He actually didn't want. And so I think that, even if a small percentage of patients are willing to go down that path, the benefits that they will reap, I think that's the selling point. And, if they fail tapering and if they fail their attempt to get off the medications, well then, you can always go back to the starting place. But it's worth the adventure, I think.
Okay. I have one other question that I want to get to, and we didn't talk really about contracts today, although that is one of the recommendations in the CDC guidelines, is to have a contract with the patient about their utilization and their utilization of the opioids and what their role needs to be, their commitments. But the question that we had was, won't requiring a contract just drive patients at risk of addiction to street drugs as an alternative? So either physician.
Sure, I'll jump in, and then Dr. Sobel, I'll let you add as well. I mean, the answer to that is yes, that can happen. But at the same time, I don't think that we should see this as all that different. If there are patients who are addicts, who are using this medications because they are addicted, and that's really the central issue. It isn't their pain relief or the treatment of their chronic pain, but because they are addicted, we are obligated to make sure that we give them help. So our pain contract is fairly strict, and it requires a lot on the patient's part, which I will resist the temptation to go down the rabbit hole of patient engagement, because I think that's critical in managing patients on chronic opioids. But if the patient fails a contract, our methodology is not, you failed, goodbye, sorry, and it's over. It's, okay, let's talk about why you failed. You were doctor shopping. Why are you doctor shopping? You're in drug screen that either has an absence of the medication, which would mean that they're really not about to withdraw, or that you have street drugs, illicit drugs on top of this. And we really spend time with that patient with an exit strategy. And so a lot of times that results in a referral to behavioral, mental health, substance abuse treatment, and we really work with the patient. A lot of times those patients, if they come in and they have cocaine in their urine as well, we don't say, well, you're cut off from your opioids. What we say is, we're going to taper you off your opioids. You failed the contract. We can no longer write those medications, but what we really need to do is get you the help that you need. And are there patients who we release from the program because of, for nefarious reasons, who then I believe are out on the street using heroin? I do. But I think our job in the medical community is to control our side of it and stay on our side of the equation. And that doesn't mean turn a blind eye to people buying street drugs. I'm just saying, because we have some hand in this epidemic, I think we have to keep our hand in towing the line and doing the right thing case by case as every patient comes in. Dr. Sobel, what do you think about that?
Yeah, I agree. I mean, I think a contract, importantly, a contract is an agreement between two people. And I think the contract tells the patient, and you'd say to the patient, I am willing to help you using the best of my medical ability and whatever resources I have to help you get off these drugs. But at the same time, you're making an agreement with me that you're going to do your best on your side to follow through. So like any contract, it's no different than any other business contract. that two people are committing their best abilities to fulfill an agreement. And so I think it's an assurance to the patient, if they're serious, that you're going to stick with them. But half of the contract says they're going to stick with you and do what needs to be done. Kind of changes it from a, the omnipotent physician to the patient who is the lowly patient, to somewhat equals. So I think that works in that way.
It's an excellent perspective. So I want to thank you both for participating in that question and answer session. I know we wanted to cover a lot of that topic area, and we really did think it was better to do it as a conversation as opposed to just presenting more slides. But now we're up to our last polling question, and so Valencia, I'm going to hand it over to you to read the question.
And this question states, I feel that I can implement the following practices reviewed today with my patient population and make a difference. Please select all that apply: guidelines for acute pain management, guidelines for chronic pain management, CDC guidelines for managing opioids for chronic pain, MMME dosing calculation, PDMP review at every visit. We have about 36% that have participated in this poll. Just wait a few more seconds.
You can read the results now, Valencia. I'm looking over her shoulder here so I can see them, so I'm very pleased with what I'm looking at.
Yes, it looks like we have 100% for all of the ones that apply.
So that's great. In other words, we're really willing to try whatever it takes. Look at this from all angles and try all the things that we need to try to really help our patients in this area. So I'm going to close this just by pointing out a couple of things, and I do want you to hang on a minute until I kind of get through this. First of all, in your control panel, there is a handouts tab that you can open up, and if you open up that handouts tab, there are 5 handouts in there. One is this PowerPoint presentation. So it will, if you download that PowerPoint presentation, it will have all these resource links available to you. There are also 4 other handouts in there. They're specifically the ones that were mentioned in the previous slides while Dr. Sobel or Chenard were talking. But at the end of the presentation, there are 3 pages of resources with direct links. So we took the time to go out and find the direct links that will take you right basically to these PDF files so that they're easy for you to retrieve. But there are quite a number of them. We have several acute pain management guidelines, including the 2 that Dr. Sobel referenced in his slides from the American Pain Society and the AAFP. We have quite a few chronic pain management guidelines, including the CDC guidelines, and a CDC checklist for prescribing opioids, which can be really convenient, that are available out there to be printed. And then some general resources. I do want to call people's attention to Quality Insights, the Quinn QIO in Delaware, who has a really good and exhaustive opioid reduction initiative page. That's the link to it. It has just more resources than you can imagine, and it has a lot of information that you can use directly with patients, patient education, as well as tools that you can use within your own practice, assessments, things like that. And then, of course, the sites where we were able to gather a lot of our information and that offer a lot of information on managing pain. The other thing that's in there that I really wanted to share with you, and it's an Excel spreadsheet in the handouts bar, is an inventory of addiction treatment centers in our area. We pulled this together, and it's probably not a totally complete and exhaustive list, but it is a place to start to provide some information for our practitioners, our providers, on addiction treatment centers that are available in our communities. Sometimes just through our assessment and through our evaluation of our patients, we do realize that they need help that we can't provide them. These centers are out there and available, and many of them can provide assistance for little to no cost, and have some really proven success rates within their programs. So we would welcome you to print that out and have that available should you need to call on that. And then community involvement. I'm going to talk about that in two ways. Right, you see on your screen right here an announcement for a session that's going to take place in our community in Salisbury at the Wicomico Youth and Civic Center on Thursday, October 19th. It's called Taking Back Our Community, and what it is a full community conversation, not just the medical community, but the social service community in the area, the religious community in the area. Many support services, many different organizations are planning to attend this and basically join a discussion about what are the things that we can do by banding together to help solve this problem within our community. And then finally, if we think about our TCPI community, you know, all of you who are on this line are either participants in the TCPI program through our Practice Transformation Network, or work with one of our related ACO partners, one of the ACOs in the area who we collaborate with in our medical communities. We're really asking as a community of practice that our members really commit to making a change in this area. And to that end, the TCPI community, and this is the address that you can go to see this, the TCPI community has created what we call the Medication Management and Opioid Initiative Pledge. And basically the pledge says, I know I can't solve it all myself, but I'm willing to do whatever I can to do my part to help in this crisis. And I would ask that all of our PTN members, certainly, and any other member, non-member practices who are on the line, take a moment, share this with the clinicians in your practice, ask them to go out, click on that link right in the middle of the screen. It will take you right to the pledge, and read that pledge and see if you too can't join us in taking this pledge to help reduce the opioid crisis in the community. So that being said, that wraps up our presentation for today. I truly appreciate you joining us at 5 p.m. We wanted to be able to get as many clinicians on the line as we could, and I see that we did have a number registered. So I'm really happy that you could join us. We will work to get this uploaded to our YouTube page within the next couple days, and that way we can share it even more broadly across our network. So thank you so much, and everybody have a great evening.